Welcome, everyone. My name is Alyssa Frank, and I am a senior product manager focused on oncology testing at Mayo Clinic. I will be moderating today's session. I would like to welcome you to our Advancing Care Through Genomics virtual speaker series. This particular series will focus on presenting new information and ideas in laboratory medicine and pathology in individualized medicine. Today is the first presentation in our multi-part series. Before we get started, I would like to mention to please use the Q&A in Zoom to submit your questions. We will have planned time for Q&A at the end of this session. We are now delighted to welcome Dr. Kevin Halling as our featured speaker today. Dr. Halling is the co-director of the Genomics Lab and a professor in the Division of Laboratory Genetics. He received his MD and PhD from the University of Kansas, and he completed an anatomic and clinical pathology residency and clinical molecular genetics fellowship at Mayo Clinic. His primary area of interest is in the development of genetic tests that can be used for the diagnosis and treatment of a sporadic and hereditary cancer. Dr. Halling will be talking today on comprehensive genetic profiling to guide cancer treatment. Each cancer patient faces a unique journey based on several factors, including their specific disease, clinical history, and individual preferences for treatment. Recent advantages in genetic testing now provide a wide range of genomic data that can be used to guide and personalize treatment decisions. Comprehensive genetic profiling provides insights into genetic alterations, biomarkers, treatment options, and clinical trials to help provide physicians with the information they need to guide each patient's journey. Please join me in welcoming Dr. Halling.
Thank you, Alyssa. And thanks for the opportunity to speak today to the SIM group and others. So I'm going to talk about comprehensive genetic profiling to guide cancer treatment. And I have no financial disclosures relevant to this presentation. My learning objectives are shown here, so I'll provide a brief overview on cancer genetics and clinical molecular oncology testing. I'll detail the benefits of comprehensive genomic profiling, which I may abbreviate as CGP at times. So the benefits of CGP for solid tumor patients. And then finally, I'll end with some case studies that illustrate significant findings and advantages of the testing. So cancer, I think we all know this. Cancer is a genetic disease that results from mutations in cancer-causing genes that are known as oncogenes and tumor suppressor genes. There are about 20,000 protein encoding genes in the human genome, but only about 500 to 1,000 of these contribute to cancer formation when mutated. And for example, we know that mutations in certain genes, such as hemoglobin or collagen or albumin, are unlikely to contribute to tumor genesis when mutated, whereas other genes, such as the RAS genes, EGFR, P10, P53, can contribute to tumor genesis when mutated. So oncogenes promote tumor genesis through activating mutations, in other words, mutations that increase the activity of the proteins that they encode, whereas tumor suppressor genes lead to tumor genesis by inactivating mutations. Mutations can occur both at the chromosomal level and at the molecular genetic level. Examples of chromosomal level mutations include translocations, such as the one shown off to the right there, the famous Philadelphia chromosome that occurs in chronic myelogenous leukemia. Copy number variants are a common chromosomal abnormality, showing up either as chromosomal gains or losses. Then you can have gene amplification, and then you can have inversions. So those are just some examples of chromosomal level mutations. And then a lot of mutations occur at the molecular genetic level or submicroscopic level. And we refer to these as either single nucleotide variants or SNVs, or small insertions or deletions, which we refer to as indels. So we have lots of tools in the laboratory. We now refer to it as our genomics laboratory, but it's an amalgamation of the cytogenetics lab and a molecular genetics lab. And so some of the tools that we have for assessing tumors for mutations are shown here. At the upper left, is showing a chromosomal microarray. And these are displayed with copy number alterations from left to right, showing chromosome 1, 2, 3, et cetera, all the way through chromosome 22, X and Y. So in this case, you're seeing a gain, I think it was chromosome 7 here, and a loss of a chromosome 10, and then looks like there's an amplification of a gene right here. So that's a powerful tool for looking for chromosomal abnormalities. In the past, until recently, we've used Sanger sequencing to look for SNVs and indels in tumors. And that's largely being supplanted by next-gen sequencing. Another tool that we sometimes use for looking for chromosomal abnormalities is FISH, or fluorescence in situ hybridization, looking for translocations or gene amplification or deletions. Until recently here at Mayo, we've mainly been offering tests for individual genes such as KRAS or EGFR, or small targeted NGS panels up to about 50 genes. For instance, we went live with a 50 gene cancer panel about 10 years ago, which we call our CAPN test. And after launching that, we were told by some oncologists that they don't want information for all 50 genes, so we created some subpanels. For instance, we had a 4-gene panel for colon cancer and a 2-gene panel for gastrointestinal stromal tumors and other ones too. But recently, in April, we went live with a large cancer panel, which we now call Mayo Complete Solid Tumor Panel, which is an example of comprehensive genomic profiling. So what's the clinical value of detecting mutations in tumor? Well, it really falls into 3 buckets. Perhaps one of the most exciting areas is using that information to predict response to therapy. But we also frequently get information that's helpful for establishing a diagnosis or predicting the patient's prognosis. There are a number of useful biomarkers that are coming about over the last decade or two that are useful for predicting response to therapy in various tumor types. For instance, in breast cancer, looking for mutations in PIK3CA, HER2, BRCA1 and 2, and the mismatch repair genes can help predict response to therapy. And so I won't go through all of these, but you can see there's a lot of markers that are becoming important and are being recognized in US guidelines and drug labels for common solid tumors. Additionally, there's some very important markers that are important for virtually all solid tumor types, and we refer to these as pan-cancer markers such as NTRK fusions, tumor mutational burden, and microsatellite instability. And in fact, in the last 4 or 5 years, there's been several FDA approvals for these pan-cancer markers. In 2017, the FDA granted approval to assess all advanced tumors, advanced cancers for evidence of defective DNA mismatch repair, either through the DNA mismatch repair immunostains or by microsatellite instability analysis. And that was the first example of the FDA approving a drug, basically pembrolizumab, which was agnostic to the tissue side. And then in 2008, the FDA approved the use of larotrectinib for solid tumors that had NTRK gene fusions. And then recently, FDA approved pembrolizumab for tumors that had evidence of a high tumor mutation burden. So you can see all the approvals that have occurred over the last couple of decades. There were a couple approvals for EGFR for the use of gefitinib or erlotinib for patients that had EGFR mutations in the early 2000s, and then there was a hiatus for quite a while. And then starting in 2010, there was sort of a flurry of new approvals. And so you can only wonder what's going to happen in the coming decade. But these approvals have been for things such as drugs for immunotherapy, for drugs that are targeted to RET, or MET, or EGFR, or ALK, ROS, BRAF, or NTRK. So let's talk a little bit more about comprehensive genomic profiling because of the value that it has. Well, so why is this important? Well, comprehensive genomic profiling provides the most information, a lot more than you can get from single analyte assays or even small NGS panels. And it's the only way to get information on tumor mutational burden. There are simpler assays for microcellular instability, but it's nice to be able to have that information concomitantly with all the other alterations. The comprehensive genomic profiling is being increasingly recommended by various groups such as NCCN and ESMO. And comprehensive genomic profiling allows you to enter patients into clinical trials. And so you can, on this slide shows that the NCCN, for instance, is recommending TMB testing for a wide variety of tumor types, and then NGS testing for a lot of additional alterations in many different tumor types. And ESMO, which stands for the European Society of Medical Oncology, is similarly recommending CGP. One of the benefits of comprehensive genomic profiling is that it enables one to identify alterations that may allow you to enroll a patient in a clinical trial. There was a study done a prospective study done of 10,000 patients with advanced cancer, and they found that based on the CGP results, they were able to enter about 11% of their patients onto clinical trials. The other benefit is that it's been estimated that about $25,000 per patient can be diverted from payers to clinical trial study sponsors by this testing. And then finally, by doing comprehensive genomic profiling, it allows you to enroll patients in genomically matched trials that may lead to clinical benefit. All right, so as I said, we went live with our large cancer panel in April of this year. And again, it's called Mayo Complete Solid Tumor Panel, abbreviated as MCSTP. It utilizes Illumina's TSO 500 chemistry and pipeline. It's basically 6 cancer tests in one. So we extract DNA and RNA from the tumor. And from the DNA, we perform our DNA panel, which assesses for mutations in 514 genes. When I say mutations, I mean single nucleotide variants and indels. Looks for amplification in 59 genes, things like HER2. It provides a TMB result. And maybe you all know that, but TMB is divided into TMB high or high tumor mutation burden cases and TMB low cases. In any case with a mutation burden of more than 10 mutations per megabase is considered TMB high. You're only going to be able to get TMB results from large cancer panels such as this. We also get an MSI result, either MSI-H or MSS. And then on the RNA side of things, we're able to detect fusions of 55 genes and splice variants in 3 genes, those being the androgen receptor, the MET oncogene, and EGFR. So as I said, live in April, we've obtained New York State approval. We've assessed about 450 patients with the assay. About 70% of our patients samples have been from Mayo patients, and about 30% from Mayo Clinic laboratories, and about 70% have been lung cancer patients. So this shows the 514 genes in this panel. This panel was designed by Illumina. It was designed to include, address current guidelines and emerging biomarkers. It has 100% coverage of NCCN guidelines for 11 tumor types and coverage of genes involved in 1,600 clinical trials. All right, so when we analyze a patient for a patient's tumor for alterations, we have to determine whether those alterations are clinically significant or not. And to do that, we utilize the standards and guidelines for interpretation and reporting of sequence variants in cancer that were established by a joint consensus committee between Association for Molecular Pathology, or ANP, ASCO, and the College of American Pathologists. And so what that group recommended was that variants be interpreted either as tier 1, tier 2, tier 3, or 4 variants. So tier 1 variants are variants that have strong clinical significance, either therapeutic, diagnostic, or prognostic. And tier 2 are variants that have potential clinical significance. Tier 3 variants are variants that have unknown clinical significance, and tier 4 are just benign variants. So in our reports, we report all the tier 1 and 2 variants and provide an interpretation for those. We also report the tier 3 variants, in other words, the variants of unknown clinical significance, but we don't interpret those. And we do not report the benign variants. Now, there's a lot of work involved in this, so we decided early on that we were going to utilize a genomic interpretation tool to help us categorize the variants for any patient's case, and also provide clinical trial data. So we use a tool which is known as QIAGEN QCI's tool to do this, to interpret the variants and provide clinical trial information. Typically, we see about 3 to 7 variants on a case if it's not hypermutated. But if it's hypermutated, we can see significantly more variants than that. This shows an example of a patient report. This patient, so this is a results section of the report. This patient had lung adenocarcinoma, and you can see they had several variants. So the patient had a high tumor mutation burden, 15.7 mutations per megabase. A microsatellite stable phenotype. They had an EGFR mutation, a KRAS mutation, a BAP1 mutation, and a mutation in INHBA. So this just shows you sometimes we do see alterations in some of the less common things. And then the second column shows us how we interpreted them in terms of their tiers. And so TMB is a tier 1 alteration. And there is an FDA-approved therapy for that, so we indicate that here. The EGFR mutation was also a tier 1A mutation. And then some of these alterations were tier 2C. So we have another column indicating whether there was an FDA-approved therapy for this particular alteration. And then we have a column indicating whether there's an FDA-approved therapy for other tumor types. Also, we indicate if there's any clinical trials available. And we used to have a column indicating that whether there was diagnostic or prognostic information. We've removed that column and instead have put that directly into the interpretation. So we still provide that information. So after the results section, we interpret the results. So for instance, this patient, as I said, had a high tumor mutation burden. So below that, we indicate that the patient may respond to therapy. We also indicate the EGFR mutation may respond to anti-EGFR therapy. Next slide. And towards the end of the report, we'll list any clinical trials that are available. And this data is pulled from clinicaltrials.gov. And so in that, you'll see the alteration again, the trial ID, the title of the trial, and any contact information. All right, as I said, about 70% of our cases are for lung cancer, so I thought I'd talk a little bit more about that. So in the past, what we used to do for lung cancer patients is we'd assess for the most important alterations usually with single gene tests. So we have a PCR test for EGFR alterations. We'd either have immunohistochemistry or FISH for fusions in Alcross, RET, or MET. A PCR assay for MET exon skipping, PCR assays for BRAF, KRAS, and HER2. But as you might guess, that can use up a lot of tissue, getting slides for all these different tests. And it actually, in the end, can take a lot more time to get results in this fashion than it would if you just ordered a single large cancer panel, a single comprehensive genomic profiling panel. Advantages so far are that you waste less tissue and overall you get your results quicker, and then you don't miss alterations. This slide shows a nice study that was done all the way back in 2016, where they looked at 6,832 non-small cell lung cancer patients, and they found comprehensive genomic profiling identified NCCN recommended actionable alterations in 71% of patients. And the 29% that did not have an NCCN actionable alteration frequently had an alteration that would allow them to be enrolled into a clinical trial. Some of the common alterations that were observed amongst the 71% were KRAS mutations, EGFR mutations, ALK, BRAF, HER2, et cetera. So actionable alterations for which there were drugs available. Okay, one of the most important reasons for doing CGP, a large cancer panel, is that that's the only way to get an accurate tumor mutational burden result. And this study nicely discusses that. It shows you that basically the panel needs to be at least 1.5 to 3 megabases in size to be able to accurately determine tumor mutational burden. The TSO 500 panel that we use is 1.94 megabases, so right in that 1.5 to 3 range. If you try to use a small next-gen sequencing panel, there's a potential to either underestimate or overestimate tumor mutation burden. So that's why you'll need, if you want this result, you need a big panel. One problem that labs across the country have had that I wanted to mention with large panel testing is that tissue insufficiency is frequently an issue, either due to insufficient quantity of tissue or quality. And this has been found to be the case for about 25% of lung cancers and about 20% of other tumor types. And the lung cancer specimens can be particularly difficult because they're frequently quite small. So that's why 25% versus 20. I do want to say that one thing that can help, I did mention the quality issue. So getting specimens preserved quickly is helpful. Mentioned that there's a DNA side to the test and an RNA side. We found that the RNA degrades more quickly. So the more quickly you can get samples reserved, the better, especially for RNA preservation. All right, after going live with the test, we noticed that we were having to cancel some cases because of insufficient tissue. So these were 5 cases that this is what was left in the block once we got it. So it had been exhausted for other things, sometimes immunostains or other. Here are 6 cases that were on the smaller side, sort of suboptimal. So these can be a challenge to get to work. We've been pushing harder and harder to get these to work, and we're having some success. But frequently we need to cut as many as 20 unstained slides to get enough DNA and RNA from samples like this. And if the tumor starts to peter away as you go through the unstained slides, you can see the issues we're dealing with. Something like this is more than enough. So, but it doesn't have to be this big. I do want to mention that, you know, if we're having a struggle getting enough, getting a paraffin specimen to work, that we can utilize cytology specimens. We are validated to use cytology specimens, and they frequently work very well. The quality oftentimes is excellent, probably because the fixatives that are used for cytology are less harsh than those that are used for formalin. So, and if you ever have questions, we're always happy to work with you. We actually are piloting the sort of a telepathology program with our Arizona site to review images digitally to make sure that there's enough tissue available to proceed with testing. All right, I want to end with a few case studies that demonstrate the different types of alterations that we identify and their actionability. So the first case was a 64-year-old female. She had lung adenocarcinoma, and when we did the large cancer panel, or MCSTP, we found she had a high tumor mutation burden, 32.9 mutations per megabase. She had a microsatellite stable phenotype, which basically tells you that the etiology of these mutations is not defective DNA mismatch repair, which is usually the case for lung cancers. She also had a truncating mutation in the BRCA1 gene. suggesting the possibility that PARP inhibition might be helpful, even though there's no FDA-approved therapies. She had a P53 mutation. P53 mutations, of course, are very common in lung cancer. And she had a TERT mutation, promoter mutation, which are generally associated with a worse prognosis. So this is that same patient. This is just showing the clinical trials that are available for BRCA1 mutations, PARP inhibitors. So case number 2 is a 79-year-old female with cecal adenocarcinoma. She had a very high tumor mutation burden at 54.6 mutations per megabase. She also showed microcellular instability. So in this case, this is showing you that the patient's tumor has defective DNA mismatch repair, and the etiology of this high tumor mutation burden was, in fact, that defective DNA mismatch repair. Patient also had a V600E BRAF mutation, which indicates that the patient is very unlikely to have Lynch syndrome. So this is likely a sporadic colon cancer that has defective DNA mismatch repair. Also had mutations in KRAS and NRAS, and both of those would predict resistance to EGFR therapy. And then finally, there were 15 additional tier 2 variants. And as I said, we frequently see a lot of variants in patients that have a high tumor mutation burden. This was a 68-year-old male, had metastatic urothelial carcinoma to a lymph node, also high TMB, a microsatellite stable phenotype, had a ERB3 missense mutation, which was considered a tier 2C, P53 mutations. P53 mutations, of course, very common in bladder cancer. MICL1 amplification, which is considered 2D, and a TERT promoter mutation. And the significance of that one is bladder cancer patients with TERT mutations tend to have an unfavorable prognosis. I did want to, the reason I put that last case in there is there was a paper that came out recently that showed that high tumor mutation burden fails to predict immune checkpoint blockade response across all cancer types. And in that study, what they basically found is that immune checkpoint blockade was predicted by TMB for melanoma, lung cancer, and bladder cancer, but not for breast, prostate, and glioma. And they postulated that the reason is that for cancer types where there was a response, there was a positive correlation between CD8 T cell levels and neoantigen load. So that last case, which was a bladder cancer, would be predicted to respond, but just should keep in mind that there are certain tumor types where at least this study is predicting TMB is not going to predict response. This fourth case was interesting in that it sort of highlights the fact that the assay sometimes provides diagnostic information that's very useful as opposed to therapeutic. So this was an 11-year-old male that had a type of rhabdomyosarcoma, which was referred to as a spindle cell sclerosing rhabdomyosarcoma. And there is a particular mutation that's basically diagnostic for this entity. And it's L122R mutation in the MyoD1 gene. And when we did the sequencing, we did in fact find that. So that helped them establish the diagnosis. This case illustrates, I talked about the fact that we're able to determine if there's amplification of genes. And whenever we do our sequencing, we plot out the copy numbers for each of the 514 genes in a plot here. So we arrange them from chromosome 1 through 22 from left to right, and then Y and X genes. And what you're seeing here is, so these ones right along here, the baseline are copy number of 2. This would be showing loss of short arm chromosome 1, gain on chromosome 13. But what's particularly interesting is there are several genes that are amplified here, and they are the CCND1 gene, which is the cyclin gene, fibroblast growth factor 19, 3, and 4. So they're basically showing co-amplification, and this is a fairly common phenomena in esophageal cancer where you see co-amplification of these. There are not FDA-approved therapies for this, but there are clinical trials, and we did list them in our report. This is the last case. This one shows a patient with a fusion. So this is a 69-year-old female with metastatic lung adenocarcinoma, had a low tumor mutation burden, only 4.7, microsatellite stable phenotype. And this patient, interestingly, had a KIF5B RET fusion. RET fusions, RET can be rearranged with a number of different 5' partners, which is one of the benefits of comprehensive genomic profiling, because it's able to pick up RET fusions regardless of the 5' partner and regardless of the breakpoints. So that's actually sort of shown over here to the right in this paper here. They're showing RET being fused to a number of different other 5' partners, and the breakpoints for the 5' partners can be quite varied too. So the advantage of the tests that we use is that we can pick up all of these. And clinically, the important thing here is that this fusion responds to a couple of FDA-approved drugs that were just approved a couple of years ago, known as selpercatinib and pralsetinib. So that's almost my last slide. I do want to thank all the people that were involved in developing, validating, and implementing this test, include various lab directors and pathologists, development technologists, bioinformaticians, technical specialists, the genetic counselors who help us prepare our reports, the management group and IT group, and our product manager, Alyssa Frank. So to summarize, I hope I've showed you that comprehensive genomic profiling enables a consolidation of biomarker tests into a single assay, which allows for sample preservation. And in addition, it can actually improve your overall turnaround time as opposed to sequential testing of single analytes. I think I've shown you that, our testing assesses both for DNA and RNA variants, and it assesses for pan-cancer markers such as tumor mutational burden, microsatellite stability, and NTRK fusions. By doing CPG, you maximize your ability to identify actionable variants, and that improves your chances of molecularly matching therapies in clinical trials to provide better clinical outcomes. And then finally, a reminder that we can do this testing both on paraffin specimens and also cytology specimens. And with that, I'm finished with the talk and happy to take any questions. Thank you.
Perfect. Thank you, Dr. Halling, for your presentation. Great information. So we can move into the Q&A section of our presentation. How is the process to update the NCCN guidelines and integrate into the pathology reports? Is it through a review committee at Mayo?
No, that's part of the QCI tool. They actively update all that information, I think, on a monthly basis. So that was one of the reasons we wanted to go with that tool, because it's almost impossible for a laboratory to do that. And they employ, I'm told, a very large number of postdocs to help keep that information constantly updated.
Great. And on a similar topic, can you talk a little bit more about the process for updating the test in general? So say an NCCN update comes through, how often are you looking to update the test, or when would those type of guideline changes make it through?
Well, it's a very big task to validate a test like this. It took us a year and a half to validate it. So, and also for the manufacturers, they're unlikely to change this panel soon. And 514 genes is quite a large number. So I think it's unlikely that there's going to be a lot of additional ones. We actually are currently working on RNA-seq using whole transcriptome analysis. And so there's always a potential to find variants that way. And you wouldn't actually have to ever update anything because you've got the whole transcriptome there.
I don't know if you'll know the answer to this right off the top of your head, but the question is, was case number 6 a non-smoker or someone who had never smoked before?
Yeah, no, that's a very good question. I looked that up, and the patient actually surprisingly was a smoker. But I think the person who asked the question is is right that patients with RET fusions, ALK, ROS generally are non-smokers and younger.
Great.
The other thing
thank
that was
you.
interesting about that case, which we frequently see, is those patients that have fusions, those lung cancers that have fusions frequently almost always have low tumor mutation burden and relatively few other alterations. So it fit in that sense. So.
Great. A few more questions are coming in, so definitely keep them coming. The next one says, hi, Kevin, nice presentation. I'm wondering whether you know the mutations in the TP53 gene are heterozygous or homozygous mutations. Also, what is the major reason for your group to mainly focus on lung cancer, but not the other types, such as CRPC? So maybe for this question, you can talk about some of the other cases we've seen or other tumor types for CGP, and just talk about, you know, some of the results we've seen there as well.
Sure. Let's see. The first question was about P53. Yeah. So we, you know, if there were two either SNVs or indels, that we'd be able to easily see that. You know, they would be either you know, compound heterozygous. But we could, you know, frequently what happens with P53 is you get like an SNV or indel on one chromosome and a deletion on the other. We actually can look at our copy number data to see if there was a allelic deletion on the other chromosome. So we can tell if they're homozygous. The other question, so the reason we focused on lung cancer is because that's a predominant tumor type that we do get. And a lot, you know, tumor mutation burden has become a very important aspect of lung cancer treatment. So that's probably why that's a predominant tumor type, and also because lung cancer is very common. But we have had many interesting cases from other tumor types. So we have that information too.
Do we have testing biomarkers for lung squamous cell carcinomas? Tyrosine kinase gene, like EGFR mutations, are rare in this type of cancer. Yeah,
we do. We, you know, with the 514 genes, we have genes that are altered in squamous cell carcinoma of the lung. So.
Perfect. So the next question is there any challenge for reimbursement if the test requests originate from different states outside of the Mayo network?
So there are 7 Medicare carriers across the country, and they cover different regions. And Palmetto is a Medicare cover down in the southeast part of the country. And they have a program called the MolDX program, which is for basically determining reimbursement for molecular tests such as this. So we submitted a test packet to them showing our analytical validation, and they approved it, and they accepted, you know, they are going to provide reimbursement. So that's the southeast part of the country. Actually, in our region, which is National Government Services, a decision hasn't been made on this yet. So it varies a lot across the country, but frequently a lot of the other carriers will look at what Palmetto's done, and based on that may provide reimbursement. So
I know you mentioned earlier about tissue being a big issue, right, for next generation sequencing, especially CGP. So if you want to talk a little bit more about what Mayo Clinic is doing to help ease this problem, or if there are any best tips for everyone on the line to ensure that they're getting, you know, their specimens processed and their patients' results.
Yeah, so as I said, we're always happy to work with our Mayo physicians and our MCL clients to review the tissue that's available, to try to pick the best block, for instance. And we actually have a tissue slide review process here where we go through the blocks and make sure we're using the correct, you know, the best block. We also, as I said, are established a telepathology program with Arizona. I hope in the coming years that we can expand that and make it available to anybody who's interested in submitting images in advance. There may be times when there's nothing available that we can use. And so we're currently working on a cell-free next-gen sequencing assay that could be used in such instances.
Great answer. So we did have one more come through. It is, are we able to run this test on stored specimens?
Well, I don't, other than paraffin, you know, definitely. I mean, we can analyze a paraffin block that's fairly old, as long as it's not too old. So, but we've analyzed specimens that are 20 years old. So have to keep in mind that sometimes that there's things beyond our control that will affect RNA quality in particular, such as ischemic time in the OR can lead to a lot of RNA degradation. So working with the surgeons to make sure that those samples are processed quickly too can be helpful. So.
Perfect. Well, thank you so much for your time and for sharing your knowledge, Dr. Halling. And thank you to our audience for joining us for this first session in our series. The next presentation will be on December 17th on the topic of CAR T therapy. So if that is of interest to you, feel free to register for that session. Otherwise, thanks for tuning in and have a great week.
Thank you.
Thank you.